So the last VA and VV and the physiology has made my talk much easier, and I'll try to stick to the time. In the next 15 to 20 minutes, we will be discussing a little bit about the ECMO cannulation. The ECMO cannulation is one of the most important part of ECMO initiation, and a good ECMO cannulation helps in a smooth run of ECMO. And ECMO cannula is the interface between the patient as well as the ECMO circuit. So this is important, most important part in the initiation phase. So we have learned there are the two types of ECMO, and according to the two types of ECMO, the cannulation strategies will be different. So for drainage of blood, we use usually the femoral vein, where we put the cannula right up, which goes right up into the hepatic portion of the IVC. Tip is in the IVC RA junction, and where we are draining, we are draining to the circuit, and then from the pump and oxygenator we give back the blood. The return blood is usually given into the internal jugular vein. For the arterial cannulation, we usually use for the peripheral VA ECMO. As you have seen, we are using the femoral artery, which can be either right or left, and we can also use the subclavian artery at times. We can also use the central configuration of ECMO. The central cannulation is where, like in cardiac surgical patients, the patient is not being able to come off cardiopulmonary bypass. The patient is already cannulated. The aorta, the RA or the IVC, SVC have been cannulated, and we just disconnect the circuit from the pump and we connect it to the ECMO circuit. So before we jump into the cannulation, the things that we need are the cannulas of various sizes, the drainage and cannulas. You determine by the ultrasound. We check the vessel size and determine the size of the cannula that we want to use. And you should also have at one size and two size down below the cannulas that should be present. There are circuits which have we need to supply gloves and drapes. So before we check the ultrasound and we do the sterile preparation and draping. Am I audible now? And is it okay?
Yeah. Now it's okay.
So before we cannulate, we do the ultrasound guided vessel identification, and we cannulate like we are putting a central line. Remember what we do. You see the vessel by ultrasound. We put the needle, see the free flow, put the guide wire. Here, after putting the guide wire, we are giving a bolus dose of heparin. And after that, we are serially dilating the vessels. Why serially dilating? I will come to it later. And after appropriate dilator use, then we put the cannula. When we are cannulating, always remember that the patient may be hemodynamically unstable. So a couple of people should be taking care of the hemodynamics of the patient. And after we have put the cannulas in, its proper positioning has to be ascertained by ultrasound, by echo, or your X-ray. What are the common complications that we find? Bleeding is the most common complication, mostly because either the patient has received a heparin doses for that, but most commonly it is because we are not careful. Sometimes we cut the skin or we are very forceful with our dilators and which lead to vascular injury. And if there is vascular injury, there is a massive bleed and it will be very difficult to contain. In ECMO, we have to check for limb ischemia and infection risks are always there. What after the cannulation, we have to check whether the sites are clean. They are covered with sterile dressing, which is transparent. There is no bleeding or hematoma around the cannulation site. All these things have to be checked. And also the cannula position, how much cannula is in, how much is out, that has to be checked. Coming to the actual cannulations, venovenous cannulation, it is either two cannula technique, the most common, where we are draining blood from the IVC. We are putting the cannula in the right femoral vein. That is the commonest puncture that we take. Why we take the right femoral vein? Because the right femoral vein is a direct continuation of our IVC and it helps in cannulation. That's why it is easier to cannulate. And this blood, after passing through the pump and oxygenator, we are giving back to the patient. From where we are giving back, the return cannula usually is placed in the right IJV. And the tip of that right IJV cannula is in the junction of the SVC and RA. So this is the usual femorojugular configuration of VVECMO. Other than that, we can also, if suppose we cannot cannulate the neck, so there is some problem in the neck, we are not being able to cannulate. So we can cannulate the other femoral vein and put the return cannula where it's a long venous cannula which will go right up to high up into the RA, and we will return the blood right into the RA and keep the IVC cannula a little bit lower to prevent our recirculation. We have already learned about the recirculation in the physiology class. So these are the usual arterial cannulas or the return cannulas. It's better to say return cannulas. You have seen that they are smaller in size, they are wire reinforced, and they have a side port for your distal perfusion that we will come to later. They usually have only one or two holes at the tip because we are returning blood from through this. It's having only one or two holes. But the venous cannula, what happens to the venous cannula? It is a long cannula, the larger in size. Why large? You have seen in the physiology class that the resistance decreases with the fourth power of our radius. When the radius of the cannula is increased, the resistance is decreased, so the flow is more. So better flow with a larger sized venous drainage cannula. And this has multiple holes at the tip. Multiple holes, why? Because we are draining blood by a negative pressure. The centrifugal pump is draining blood through a negative pressure, and the vein can collapse and close one or two holes. And also, there can be a clot formation at the tip. So if there is a clot or vein is closing one or two holes, even then the flow is maintained if we have multiple holes. So there is a dual lumen cannula also. So the dual lumen cannula is the benefit that drainage and the return. And here the is from both SVC and IVC, the two holes there for drainage, and return is I. And we have put the return hole towards the tricuspid valve. That is the most important thing. We have to put it under ultrasound guide, it is echo guidance or fluoro. And we have to be very careful, recheck every time that the whole position is towards the tricuspid valve. So this is the IJV cannula that we have put in. This is the femoral cannula. You can see that these cannulas are very large. It's triple lumen, simple triple lumen for adult is a 16 gauge. These are very, very large, 25 French, 29 French. So that is why we need serial dilators of various sizes, gradually increasing dilatation. As we dilate, go on to see whether the next dilator is going smoothly or not. And finally, we use the dilator which is provided with the cannula, the stellate, and after that, we put the cannula in. Usually, cannulation for VV ECMO is done in the ICU, and it looks like a battlefield around there. Can very well appreciate the drainage cannula in the right groin and the return cannula, the bright color, the cannula. So this is a case where we have two venous cannulas in the two femoral veins, and drainage is in the right and the return is on the left. Always remember, when we are doing femoral, the drainage cannula is a little bit lower. The IVC, the return cannula will be right up into the RA. And always check the position of the cannula tips. The cannula are radio opaque, and there should be at least 10 centimeter gap to prevent the recirculation. VA cannulation, as sir has already told us, it can be either central or peripheral. Central is usually done in the theaters where we have done a sternotomy. The cannulas are in the aorta and the RA, IVC, SVC. The peripheral cannulation, here we are draining blood. The drainage is same from the femoral venous cannula, which goes into the IVC. But the drainage, the return is in the femoral artery. So the femoral artery gets the return blood. Just see, if the femoral artery has a large cannula within it, the distal part of the femoral artery flow will be blocked, and the distal perfusion cannula in. And now we also have a curved cannula. With a single cannula, we can give both antegrade and retrograde flow, where there is a hole at the angle which can give flow to the distal part of the limb. So it's a more clear picture. You can see the femoral artery where we have put in an arterial cannula. It almost occludes the arterial flow in the distal limb, and put distal cannula. Are doing it, they can put a graft into side and can put the arterial cannula there. We don't have to put a distal perfusion cannula here. So coming the when we do cannulation, as we put in the arterial line, we put in the guide wire there, and also we put in the distal perfusion guide wire. The distal perfusion cannula line is also put in there, because once the arterial cannula has gone in, we will not get any pulse there. It will be difficult to cannulate the distal femoral artery at that point of time. So this is the arterial cannula line, venous cannula line, and the distal perfusion cannula line. And we usually, for the distal perfusion, we use a 7 or 8 French sheath, which is usually connected to the side port of the arterial cannula. You can see very well, see in close pictures. The side port of the arterial cannula is supplying distal perfusion. It can also be surgical, where surgeons usually dissect the arteries and veins and they put in the cannulas under direct vision. And sometimes if the femoral artery is very much diseased, then how are you going to do it? So in that case, we can cannulate the right axillary artery, but we cannot put it directly a cannula in it. We usually put a graft into side, and to that we connect the cannula. And this is the central cannulation. The theater have and benefit of this is we have open chest. We can put in a LV, which can be the LV vein is always connected to the venous cannula. Why venous cannula? Because the vein is draining blood at a negative pressure. This is why we can give the LV vent is connected there and drain the blood. Sometimes we need triple cannulation. Or read about the Harlequin syndrome or the differential hypoxia. So where the heart is pumping out deoxygenated blood because the lung has not improved, and that is causing upper body hypoxia. What will you do? It can be solved by you can bifurcate the return into the arterial and the another venous. This is the venous return where we are giving it in the right IJV. The right heart gets some oxygenated blood which goes to the left heart, and the left heart ejects oxygenated blood too. So this is how we can treat the Harlequin syndrome. And how to know how much flow is going in the two parts. We can connect these flow meters and see what is each limb, and accordingly we have to calculate the flow. Also see that there we have a clamp in the venous line. Why this clamp? The venous return that we are giving, that is going against a lower pressure than the arterial line. So if we are not clamping it, all the flow will be going to so we will not get any arterial circulation going. So for that, we put a clamp. Sometimes most of the centers will be always remember, don't keep it always clamped, and at times you have to just release the clamp for a few seconds. Otherwise, there can be stasis of blood there and clot formation. So if you have a VA ECMO, always check the distal perfusion in the limb by checking the flow in the popliteal vessels. Popliteal artery flow, if it is adequate, the limb flow, blood flow is adequate. If you have NIRS optodes, you connect and see the oximetry difference between the two, and it will give the earliest indication of any limb ischemia occurring. Coming to the pediatric cannulations, in our center, if the body weight is than 12 kg, the according to the size of the baby. But if the baby is less than 12 kg, because the lower vessel, you can put in venous drainage cannula there. We have to create the carotidojugular ECMO. So we cannulate the carotid, we cannulate the jugulars under surgical vision, and we can go for carotidojugular ECMO. Remember, it is not only, it is a VA ECMO, but not only for the cardiac reason, but also for the respiratory reason also. If you have a double lumen cannula available for the pediatric population also, we can use a double lumen cannula where we can do a VV. But it needs expertise, not always available. So we have to go for a carotidojugular ECMO. And you can choose the largest size cannulas that can go in, because the largest size cannula will give the best flow in this population. Unless you have an adequate flow, you will have all the complications of ECMO going in the next few days. Before concluding, I'll just give an example, a couple of examples where cannulation strategies were important and what mistakes we made and how we corrected those mistakes. So this was a child of 5 years with a respiratory distress for 2 days, was referred to us, hypoxic, and you can see the patient was having a pneumonia. We did a femorojugular ECMO with an 18 French drain in the femoral, and return is 16 French. The initial flow was good. We could get down on the ventilatory parameters, but the lactate were high. But in spite of the lactate being high, the echo showed it's a good cardiac contractility. So we continued with the VV ECMO. But after some time, we found that after a few hours, the urine color has turned cola colored. So if it is a cola colored urine, then obviously the diagnosis is that is some hemolysis going on somewhere. And most commonly in the pediatric, it is because of the flow turbulence in the drainage cannula. And we checked the pre-pump pressure. It was minus 38, and it is quite high for the pediatric population. So we reduced the flow and found that the pre-pump pressure is coming down, but the flow is coming down again. And when the flow is coming down, the patient is becoming hypoxic, and we have to go up on the FiO2s. So that is not a solution. So we put in another drainage cannula in the other limb for adequate drainage. So always remember, you have to put a second drainage cannula. The pre-pump pressure minus 15, and we have good flow, and the urine color also improved. The second case, and the patient was on femorojugular ECMO, and pre-pump pressure was minus 57, very high. So we thought of putting a second cannula. And here we used a smaller cannula for the drainage, smaller in length. And this is the arterial cannula that you can see that we use for the arterial cannulation and for the neck return that we are using for the drainage. What is the problem? It has only 1 or 2 holes. And after some time, the flow in that cannula came down and the whole circuit started to clot. What is the way out? It's an emergency situation. So we had to take out that cannula and put in a proper drainage cannula in the other limb. So, and after that, the flow was stabilized and the patient improved and went home. The whole circuit was fully clotted. So, you have to be precise and your technique. Usually, the person can cannulate, but if he's not cannulating, he at least stops and helps the juniors to put the cannulas in. Second is you have to be very precise about your technique, and you have to be very much in communication with the other team members. You have to prevent complications at all costs and always have vigilance both during a cannulation as well as after cannulation. Thank you.